Again, thank you everyone for joining the session. We appreciate you coming out, wanting to learn a little bit more about improving speed and reliability for your EHR, whether it's Oracle Health EHR, Epic, Meditech, or any others. We're excited today. We've got special guest Mike Simek joining us. He leads the Volition Consulting Group. He was a former director of IT at one of the largest health systems in the US, so he's got extensive experience in improving EHR speed and reliability, and also ensuring that technology actually supports clinicians as they're delivering patient care rather than hindering that. And we also have Ryan Oliver. Ryan spent almost a decade, maybe decade plus, at KLAS Research, if you're familiar with KLAS. Now he's leading our healthcare IT solutions here at Goliath, and he is also an expert. He actually helped sort of develop the speed and reliability category from KLAS Research as far as how they look at it from a measurement perspective. So we're excited to have both of these gentlemen with us today on the session. Just a couple of housekeeping things before we jump right in. We want this to be engaging for everyone, so ask questions. You've got a question and answer panel or drop down in your GoToWebinar toolbar. Leverage that. Put your questions in there. We'll answer them during the session. We'll answer them after the session. If there's something that we can't answer during the session, we'll certainly follow up with you on that. But we want this to be engaging. We're going to do a quick poll here as we launch the webinar. And then after the webinar is over, if you just hang out for, once you click end, 2 minutes, there's a real quick survey at the end. Just helps us ensure that we're hitting the mark as far as the content that you're expecting to see when you register for these sessions. All right, so with that, I'm going to go ahead and turn it over to Ryan and Mike. Ryan, you want to kick us off with the agenda?
Yeah, you bet. Thanks, Kerry. So hello, everyone. Excited to have you here. We're going to start by discussing one of the bigger problems that, in my opinion, is also really easy to overlook. It's easy to focus on some of the cool, exciting new technologies that come out. Ambient speech is really hot right now for decreasing documentation time, documentation burden, cognitive burden on clinicians. But underneath that, there's a fundamental issue that still the majority of health systems deal with, and it's just the speed and reliability of the EHR. And so anyway, we want to spend a minute just focusing on like why are there so many health systems still have an issue with it. We want to hear Mike's experience at one of the largest health systems in the country, and the issue that they dealt with. They did a great job. That's where we'll transition to really learning a specific example from Mike Simek about how they resolved a lot of these issues, what specifically they did. I think we can learn a lot from that, some of the outcomes, and he'll share a couple of use cases, but I think outcomes are necessary to highlight in order for people to realize, like, hey, this is something that we want to invest in. Of course, Q&A, just a quick wrap up at the end, but please engage. A few things I want to make clear before we jump over to Mike too is, I was looking at the roster, everyone that registered, and thanks for your interest in registering. Mike comes from the IT department, and a lot of people, there's some from IT, very technical IT people that register, but a lot of clinician advocates. There's CMIOs that have registered for this, or some CTOs that folks that are technical, but a lot of people that are more focused on the application and that are also focused on, hey, what's this experience that clinicians are having? And so I really think it's critical for this group to understand some of the, you don't have to know everything someone like Mike Simek would know about running IT, but some of the things that are behind these issues that downstream create the clinician experience, at least have a high level knowledge of it and what some of the opportunities are that you could bring back to your health system. So I want to acknowledge that we have groups of varying interests here. I think this applies to everyone, but also Mike at one of the largest health systems in the country, they were running the Epic application. And so there's also a lot of people here that are at health systems that run the Oracle Health application. And this is very agnostic with the way we're describing this today. So don't check out if you're saying, wait a minute, does this work with Oracle Health? It certainly does. We have about as many Oracle Health clients that we've helped with with our speed and reliability program is we have Epic clients. So in fact, we have exclusive relationships with Oracle Health and Epic to do this. So I'm excited about, let's start with this poll before I jump over to you, Mike. Is that okay? So Curie will pop it up there, but it might be an oversimplification of a question, but can you quantify the impact of EHR speed and reliability on the clinician experience today? That's a simple yes or no. But it's kind of a loaded question too, isn't it? When you look at it, it's just, can you quantify the impact of EHRs? I think it would be neat to be able to talk to everybody at some point individually, and you're welcome to reach out to us after the session today to have discussions around this. You know, how do you measure that? What are the many things that impact the overall clinician experience? But we're going to hone in today on this specific question. Okay, so we got 100% saying yes. That I think I would read into that. Everybody says yes, we know that this is having an impact. Speed and reliability is having an impact. It makes sense. We got 100%, doesn't it? I think because you're here, you know that it has a massive impact and are some way trying to quantify it. We see a lot of variation in how health systems do that, but I want to get right to it. First of all, Mike, would you mind just sharing with us first, even a quick introduction, and then what was your experience when you kind of a before and after? What was the problem that you were dealing with at your health system? Would you mind just kind of describing some of the major issues and the impact it was having? And then we'll kind of go from there.
Sure, absolutely. Hey, thanks, Ryan, for the opportunity to be here with you guys, and thanks everyone that's on the webinar. Grateful for the opportunity to just chat about the experience that we had. So, you know, like many hospital networks, right? What you really want in IT infrastructure is infrastructure to be seamless. So really, your clinicians don't even know it's there. You want it to be dependable and reliable, and just be able to count on it, and not really think about it, right? That's the panacea, the end goal, right? Unfortunately, that probably isn't the case for many of you that are on the webinar today. And that was the case where I was at too, right? And, you know, first, Ryan, we talked about this a couple of times. And one of the things I'll say is the IT team where I worked was absolutely dedicated, 100% committed to resolving issues. And sometimes people don't always see some of the work that's going around in the background. So just, you know, first wanted to give a shout out to all the people that are working to resolve issues, because sometimes you know, it can be a bit of a thankless job in resolving issues. So how do we come to find this opportunity? We had in the organization that I worked in had many different subsystems, I would say, of infrastructure across the country. Okay, and some of it was you know, a little bit disparate. So you had different issues in different parts of the country, if you will. And in one of those parts of the country that we were working in, we had pretty significant degradation of performance with our clinicians, and just could not identify a lot of the root causes, right? So we did a out of budget break glass scenario to bring in Goliath and to implement it in this particular market, so that we could do a better job of fault isolation and identifying the root cause of the problem. Because as you, Ryan, you know, and probably everyone else does, there are so many different failure modes in infrastructure that it's hard to pinpoint. And really, it's a bit of a science, but really it's a bit of an art to be able to do that fault isolation and incident management, if you will. So we were able to break the glass outside of the budget, get this system, this capability implemented in, you know, quite honestly, in record time in that particular market, and begin to use it so we could, you know, deliver that seamless capability in infrastructure, so the clinicians didn't experience the degradation of service that they were seeing.
Yeah, you know, Mike, I was actually on a call this morning with a health system that was in a similar place to what you've described to me in the past, and just pulling their hair out, frustrated, back and forth with their EMR vendor, pointing fingers, and really to the point where we don't care if it's the EMR vendor's issue or ours, we just need to know what it is. and they've got their CMIO on the call saying, hey, my clinicians need help. That's a lot of interest when you're getting CTO, CMIO, entire IT teams on a call with us saying, hey, how can Goliath help? But I think you've described similar situations. Would you mind first, though, just kind of painting a picture of when you would get report from clinicians that there are problems and respond to that, to these incidences? What did that look like? You know, what would your response look like before, when you were trying to figure it out, the resources it would take, how you would try to fix these issues?
Yeah, that's a great question, and I kind of alluded to it earlier, right? So just the dedication and loyalty of the IT staff, because when you're working in a hospital network, you know, I mean, it quite literally could be a matter of life and death, right? So that's not lost on anyone, frankly. So if you had an issue where, you know, you had a degradation of performance, or, you know, performance was just totally failed, it really was an all hands on deck approach, right? So everybody getting in and tackling the problem, right? So what does that look like, right? Well, you know, you don't stop no matter what time these issues occur. So they could be, you know, first thing in the morning or late in the evening. It wasn't uncommon for us to get a call first thing in the morning, 05 in the morning, when people are doing their workouts, and you stop what you're doing because you got an issue, you've got a degraded performance that's impacting clinician experience, and you stop what you're doing and you get on. And because of the multiple failure modes in infrastructure, it could cascade across different buckets, right? So it could be you'd bring in folks from the network, you'd bring in folks from the storage team, you'd bring in folks from the virtualization team. If you've got you've got your onshore team and your offshore team, we'd bring in people from our offshore team, and it would literally be kind of an all hands on deck trying to do that fault isolation, and that's a very, very difficult process in the IT infrastructure.
How long do those last, where everybody's in there working on that?
In a best case scenario, you get on, you identify the root cause, and you're in and out in 30 minutes. But that was pretty rare, honestly, in my experience. They can go on for hours, right, trying to conduct that fault isolation. And sometimes it's really like looking for a bit of a needle in the haystack, if you will. So troubleshooting, trying things, working things. And so having subject matter experts on, it's not uncommon, I don't think, to talk, you know, 4 to 6 hours, longer sometimes if you have difficulty. I mean, if you're in your EHR, if you're using a virtualization application to launch that EHR, you know, the failure modes are multiple, right? So bringing in all of the right people, you know, you're talking, it wouldn't be uncommon, I don't think, to have 10, 15, 20 people on for 4, 6, 8 hours. That was not rare.
Sounds like fun.
Yeah, not a lot of fun. It wasn't great for morale, right? I mean, because you know, everyone, I think, generally, not everyone, but most people want to do a great job, and you're responsible for delivering a service. You take it personal when service is degraded, and when it's falling short. You know, you want to make sure that you can take corrective action as soon as possible. And sometimes the inability to restore service quickly can take a toll, right? Because we know how important it was to the impact of the clinicians.
There you go. What you just said too, for me, is great to hear, Mike. Not that you had so much trouble getting to the issue, but just the care and the response to try to figure it out. It's funny, all the years I worked at KLAS Research, very familiar with all the ARCH collaborative data, measuring the physician experience. And over and over and over, clinicians feel what their perception is: IT doesn't care, IT doesn't listen.
Mm-hmm.
That's not the case.
Well, that certainly wasn't my experience. You know, I think it starts at the top. I can tell you, you know, the leader of our organization was very focused, laser focused on, you know, he understood the mission, and that tone was set at the very high level, and everyone followed suit. And just the personal attention and dedication to resolving and restoring service was absolutely there. And I can appreciate.
If it takes you a day to fix it, the clinician's sitting there thinking like they don't care enough, but really there's 30 people back there. It just takes, if it takes too long to find, that's the perception that comes across.
I can certainly appreciate the perspective of the other side, because the other side, you know, you just want it to perform, and when it doesn't perform, it's difficult to understand the why behind it. But the complexity, especially when you have infrastructure that sometimes is disparate, or, you know, maybe systems weren't upgraded, and you've got, working through old equipment and getting through it and identifying those issues can be a difficult process. And so I can certainly appreciate the frustration, and we would feel it, right? So we would make sure that feedback was given to us when we weren't delivering. We were impacting the clinical ability to deliver services. We would know that, and it was very clear to us.
Yeah, so you engaged Goliath, and some health systems will have a great IT team with a lot of resources, a major health system like you, and use our technology immediately and just adopt it and get going with it. Others will ask Goliath to come in and do a performance improvement engagement and do a lot of the service along with a technology enabled service along with it, and just help them fix it fast. Some long-term issues. Either way is fine, but my point is, you ended up reaching out to Goliath for some help. And describe for me kind of just how that went once you got started, and how you shifted. I think this is why everybody's joining the webinar. We announced some things like, wow, this is a health system was able to reduce costs, we're able to get some great outcomes with the clinician experience. So let's just kind of walk through, if you don't mind, Mike, some of the things that what that looked like and how long it took, what specifically you're able to do.
Yeah, sure. I'm happy to talk about that, right? So, first thing I'll say is it's really cost avoidance, right? So when you're looking at making investments are difficult choices to make. It's easier to make a decision to not make the investment up front, right? And to wait till things, in a crisis, my experience is when you have a crisis, budget is no longer an issue. I guess what I would urge people to consider is, have a proactive approach to making an investment up front, because it's really an opportunity to do cost avoidance, right? As compared to really cost reduction. So we were in kind of that situation where we had a crisis. We had a break glass budget that was made available to us. I would say the collaboration between the organization that I was with and with Goliath was outstanding. And so important, right, that you're working together towards kind of a common goal, unity of effort, if you will, Ryan, right? So we had that unity of effort working towards a common goal. Goliath knew how important it was for us to be able to solve some of these problems that clinicians were seeing, and just understanding and appreciating kind of the frustration level that was persistent from our users, because we weren't able to deliver the service that they expected. And so I would say in pretty record time, right, letting a contract can be a challenge in and of itself. So we were able to kind of accelerate the administrative downtime of getting Goliath on contract, got through that pretty quickly just because of the importance of it. So we broke the glass, got the budget, accelerated the administration downtime. So we got through that very quickly. And really the implementation, I think, was quite an accomplishment. We had it, working with Goliath and working with the organization, the technicians on both sides working together, having unity of effort, collaboratively working. We got that implemented in that particular market in less than 45 days, which was quite impressive. And then, within 45 days, it then became a program, right? A system that we could use, a technology that we could use, a tool in our tool bag to help us address and, more importantly, right, resolve these issues.
Yeah, it's funny. I published 2 white papers with a lot of research behind it at KLAS around implementation. So sort of became an expert on the impact of implementations and how difficult they can be. And years ago, when I first learned about Goliath, I was actually a little bit skeptical. I'm like, wait, you can implement it this fast? And there's a logical reason why. Just the way it deploys. So really, we're working with 2 health systems right now that need to move really fast. One that I mentioned earlier, they plugged in within, once we get them the prerequisites and they get the servers, Citrix servers ready, it deployed in about 2 hours, just like a 2-hour meeting with IT. And you probably experienced something similar. And you have user data on your entire health system within 24 hours. And then it's nice to see trending data over a week or 2. And then you can really, what's going on, you start fixing it. So that 45 days, a lot of that is probably going out and fixing the issues after the first week of getting first day or 2 and then week of getting real data. It's pretty incredible.
Yeah, and I would say,
just to watch it even this morning, we're 10 days into a deployment with someone, a really desperate children's hospital, And to see them look at, oh my gosh, these clinicians right here, 140 are having a negative experience. 10 of them, it's because of a server with 10 upgrades behind, and they had no way of finding this. They've been trying desperately. Sorry, I interrupted you though. Go ahead.
No, you said everything I was going to underscore. And really, what I would amplify here is the way to do it so quickly is you got to have both parties unity of effort, right? So, it was very clear from our leadership that this had to get implemented and get implemented quickly. And so, Goliath, you can do all that you can do, but if you don't have the other organization, the other party that is lockstep with you, and we had, frankly, a dedicated team that this was their top priority. So, you're in it together because you need that organization to help you through all of the change requests, change processes that is obviously unique to each organization, right? So you got to make sure that, of course, Goliath can do all they can do, but you got to have the organization lockstep, making it a top priority. And that's what we did, right? So, it takes that unity of effort between both parties to make that quickness happen.
So to me, I look at the top of that, log on duration comes up all the time. I saw a clinician comment recently said he actually used a watch to count the log on times throughout a 12-hour shift, and it added up to 45 minutes of just waiting for log on with all the different times logged on by the end of the day. And then I read articles about people spending a lot of money on ambient speech products, which are great. They reduce the cognitive burden on clinicians, reduce the documentation time by 45 minutes. But if you're waiting to log on for 45 minutes, that clinician still is not going to be happy with their experience. So what a great outcome. What about speed and reliability? Or did you have any other use cases that you were planning on sharing?
Yeah, 45 minutes. I mean, that's unacceptable, right? I mean, that's unbelievably poor service. So what can you do about that, right? That's just an unacceptable outcome for the users, right? The service, as you're providing a service, that's just an unacceptable level of service, if you will. So we had something similar, not to the 45 minutes, right? It wasn't acceptable, right? And so really, if you're talking for anything more than a minute for log on, and that's a long time, right? So you got to be quick. And I think you said this earlier, right? So you said you guys can work in multiple EHRs, and in this case we were using a virtualization to launch Epic, and we just had a log on duration times. We're talking in tens of thousands, right, of users just had significant degraded service in login. And you can just imagine the frustration and the disappointment and just the irritation and the assumptions that people are making about what is IT doing? Does anyone care? Of course. And then the IT team is all hands on deck trying to get that resolved for them. So in this particular case, and I can compare and contrast, the before and after, but also it was really current state because we had Goliath deployed in a market, and then we didn't have Goliath deployed in other markets. And so in an instance like this, if this were outside of that market, it could be that left-hand side of this chart, without Goliath, 10 participants probably on the low end. I think this is probably a conservative estimate of what it would take to troubleshoot, fault isolate, diagnose, and implement corrective action, right? Not unusual for us in a different market to same problem, same exact problem, long on durations just for tens of thousands of users. And you can see the numbers, 4 to 6 hours, and working through that frustration. And
so this
not just. Go ahead.
No, you finish up. Sorry, Mike.
Yeah, not just degrading the morale of the clinicians, but also degrading the morale of the IT team, right? Because they want to deliver capability and troubleshooting and frustration and all that goes along with it. So in this particular instance, this was awesome, right? We had a technician from that healthcare system that I work for, and a technician from Goliath, and no kidding, in less than 30 minutes, due to this tool, we're able to work through, fault isolate, troubleshoot, diagnose the root cause problem, and resolve it in 30 minutes, right? So I mean that's insane relative
well, I don't
to
want to out anything personal, but when you and I first met, we started talking. I remember you shared with me you had missed a couple of Mother's Days over the that doesn't score a lot of points, Mike.
That's not a good place to be with your with your wife for sure. So
yeah,
but
I want to go ahead.
No, go ahead.
I was going to say, I want to underscore, I mean, you just look at your perspective. I so much appreciate like people on the clinical side seeing like, wow, there's burnout with this IT team too, and cost of that inefficiency of trying to troubleshoot and figure out where the problems are. I want to skip forward though to some of the downstream effects, even more specifically, which you've done a great job mentioning. But if you look at like, Kira, if you don't mind, I think it's like slide 10 and then 11. This is research done by KLAS Research and the Arch Collaborative, which I love. We're, as Goliath, we're Arch Collaborative members. And you can see here, they did an analysis. They have now hundreds of thousands. I think it's 500,000 or 600,000 clinician surveys on their experience with the EHR. But the clinicians are also asked, please add your comments. And they did an analysis of all these comments. And then they said they analyzed how often they would request a specific fix. And when you look at the screen here, infrastructure, KLAS couches that into the two questions of speed and reliability bucket. So what they mean by infrastructure is they're asking to please fix speed, reliability, logon times, that sort of stuff that's more usually infrastructure related. And the number one, almost tied, are documentation burden and infrastructure. So you're really fixing one of the top issues that they have. But it's interesting, it's funny, this morning when we're on a call with this children's hospital that I keep mentioning, it's top of mind because it just happened today. You know, we're looking at what's happening, and sure enough, they have their dictation device with having a lot of latency issues because of the same infrastructure. So actually fixing the issue fixed both the EMR and a documentation burden issue because it was running on the same infrastructure. So you could actually, in many cases, you're fixing the top two requested fix by addressing this issue. And then if you look at the next slide, Kira, if you don't mind, this is the impact when, I think it's slide 11, there we go. When KLAS asks these clinicians the question, hey, is the response time good enough? They're essentially asking, is it sufficient? Is their EHR speed, response time, is it fast enough? And if they strongly agree, sometimes KLAS charts are a little bit difficult to read, so I'll interpret it. If they say, yes, it's fast enough, I strongly agree, it's fine. They're giving their net EHR experience score an 86. So they're saying overall, I'm an 80, which is industry benchmark right at the highest. I don't think there's any health systems averaging above 90, none. So 86 is you're the top of the industry. If they answer one question, yeah, it's fast enough, those clinicians on average score it at the highest of the benchmark. Now, if they say strongly disagree, so this is sort of like a net promoter score, it's 136 points swinging down. So this is an issue. And by the way, if you look at indifferent, strongly agree, and disagree and strongly disagree, all of those are not scoring. A 22 is a horrible score, and there's 51,000. There's more giving it a 22 than, and if you add up all of those, it's over 50%. So that's how big the problem is. To sum it up, over half of clinicians are in those bottom three categories industry-wide on the EMR with the Arch Collaborative members. And so that's just a bit of a scope of the issue. And I mean, you can't find data that's more correlative than that. It's very dramatic swing when you fix speed and response time. No surprise that our poll in the beginning, 100% said, yes, you can quantify it to the, and correlate it to the physician experience. Let's transition for a second, though, if you don't mind, to the clinician scorecard. This is a view that I notice people, when they see it for the first time, sort of have a jaw-dropping experience. So would you mind sharing, Mike, your experience when you first started looking at the data through Goliath technology, what it means and what you did with it?
Yeah, this is a good scorecard just to kind of take a look at the capabilities that it can deliver. You can fault isolate right to the root cause of who's having an issue right here. So this was really good.
Yeah, let me interpret a couple things too for the group. When you look at what was happening at this Epic facility, well, I think with your organization, In one report, we're able to look at what I think it was 37,000 end users. This is another Epic organization as a sample where it's a real scorecard. There's, you can see at the top 10,000, if you can see 10,595 users that have logged into the system in this time frame. 1,240 are being impacted negatively. By the way, they were only having a few handfuls of complaints. So you've got, 1,200 clinicians suffering in silence when you find out what's really going on here. And then you start to notice, okay, what's the root cause? Like, what's really happening with these clinicians? And you see the clinicians, who they are on the left. We anonymized the names and changed them, but you can see also their connection speed, and that it's the location. The connection speed has latency at this location. And so all of a sudden, I'll give you a real example of a health system that's an Arch Collaborative member. They got their data back from KLAS, and it said, wow, you have a major issue with speed and reliability. And that's go fix it, right? And then they didn't know how to go fix it. They didn't know how to find where it was. There's sometimes KLAS can say, hey, clinicians at this hospital versus that hospital tend to complain more, but they still don't know what's going on there, or it wouldn't have been an issue. And then they get the Goliath data and they say, oh, it's actually a dozen clinicians all logged on to the same router on the 4th floor of that hospital, and we need to update that router issue. And it was sometimes such a simple issue.
The beauty here, of course, Ryan, and the beauty here, of course, sorry to interrupt you, but is the ability to be proactive with this report, right? To take a look and to look at your infrastructure across the board. Instead of being reactive, you're looking at where the problems are and then fault isolating and looking at what corrective action can you take, right? Proactively as opposed to reactively.
Yeah, what are your thoughts on that? Because too often, health systems come to us when they are in a lot of trouble. Right? That proactive, pay for it now versus pay for it later. What are your thoughts on that? If you're going to give some advice.
We kind of alluded to it earlier, right? I mean, for some reason, when you're in a crisis, budget becomes available, right? And the bank becomes open when you have a crisis. Wouldn't it be better though if we made sound, deliberate investment decisions up front, right? So you could, instead of getting into those crises, you could resolve those issues before they became issues, right? So I think this would be an excellent example, right? If you're having, really, if you look at the return on investment, the cost avoidance here is key, right? The cost avoidance of the lost time, the inefficiencies resulting from clinicians not having their capabilities, applications available to them. The opportunity cost of the countless number of IT professionals that are standing through, and you're bringing up another use case that we had, right? So significant latency issues with Epic, right? So this was another example of, the opportunity cost that this has created, right? So without Goliath, we'd have, up to 10 participants. Again, I would say a fairly conservative estimate. 3 hours, that's also a pretty conservative estimate. I can envision 15 participants, 20 participants, well over 4 to 6 hours resolving this particular issue. Again, with Goliath, 2 technicians, less than 10 minutes, right? So if you look at what that really is doing, it's the cost avoidance, right, of having all of those clinicians not being able to perform their job, the IT professionals that are all hands on deck trying to resolve issue. But then also, right, not just, Ryan, not just the cost avoidance, but if IT professionals are not in the troubleshooting mode, they're able to do the proactive projects, right? That was another area where there was probably a little bit of frustration, because you'd be trying to get performance improvement and working on something that would improve the infrastructure. But there was so much firefighting that it kind of prohibits the ability or reduces the ability to focus your efforts in proactive measures, right? So, the reduction of or the opportunity cost of having folks dedicated to this is not awesome, right? But even more importantly, the ability for them to be working on improvements is probably more important. And we had a bit of a return on investment calculator, if we want to jump to that, right? I mean, this is a very basic, calculator. And I think what you could do, put together a sensitivity analysis, and you can have a discussion around what the variables look like based upon, your infrastructure, right? So your incident resolution process, how many people you have on it, right? So simple plug and chug, if you will. How many people are typically on a major incident for resolution? How many hours? And I assume if everyone's on here is tracking how many incidences they're having and what the number of hours are it takes to resolve. That should be information that is readily available. How many incidents do you have per month? And then you factor in what is the cost for IT. I think these are all pretty conservative numbers, right? And you can plug and chug and do some sensitivity analysis around this. But if you look at where the return on investment is, it's very high, right? There's pretty significant return on investment in what I think is fairly conservative numbers. So orders of magnitude of improvement here available, right? And one thing I'll note here, what isn't in here is, if you calculate the cost of the inefficiencies of clinicians and the degraded performance there, it's exceptional, right? The return on investment becomes pretty exceptional.
I'm going to jump in here, Mike. I think Ryan may have lost his connection. So you're going to, oh, there he is. He's back. All right.
Am I back?
What's that, Ryan? You're back. There you are.
Was it just me that went away?
It was just you, but that's okay. We're right back in. If you would have been 2 seconds sooner, it wouldn't have even been a break. Mike was going on. So he had just finished kind of wrapping up on the ROI calculator at this point.
This is great. Did he cover it? Sorry.
He did.
My connection speed. I wanted to add to that then, if you just covered that. Thanks for doing that, Mike. And I've seen this. I wanted to add to it. There's a lot of research around, it's just such an important topic right now around physician burnout. So I want to honor that downstream effect too of, this is to save money on the IT side, but the clinician burnout, the number one contributor to clinician burnout is actually just being understaffed and staffing issues. But in the top three, two of the top three are IT related. And, a third of that is, essentially a third of the clinician burnout is EHR related, a little over a third. And then right now, KLAS just published a paper showing that about almost 40% of clinicians are experiencing burnout, and they are at high risk of turnover when they're in that category. So imagine you can reduce over a third of the effects of clinician burnout by fixing EHR related issues, which lead to high turnover. And they published the cost of turnover, the studies show, is between $500,000 and $1 million per clinician. By the time you get through recruiting, contracting, sometimes relocation costs, and then onboarding and training, and folks are losing patients that follow the clinician somewhere else, the physician. Nurses are not as expensive as the physicians, but they're between 50 and 100,000. But imagine one clinician who says, I'm fed up, I'm going to go work somewhere else that has a better running EHR system. It's extremely expensive for these health systems and disruptive. So again, the downstream effect and the return on investment of addressing this issue. Thanks for pointing it out with us. I think we also have some Q&A, but first though, I did want to ask, if you don't mind, Mike, before we go to some of the Q&A issues. I wanted to ask one other thing that comes up a lot. It's related to this finger pointing between the EMR vendor and the health system. And oftentimes there's not a common set of facts there. Did that come up in your incident response meetings?
Never, Ryan. Never happened.
Okay.
Yeah. No, there was never this, right? Nobody pointing fingers at each other. And frankly, that happened, within the organization, right? So you don't want to be it, right, when you're degrading services. So certainly there was that, right? There was the vendor pointing at the provider, IT infrastructure pointing at the vendor. There was that all the time. So certainly having a common set of facts to work from, both internally and with your partners, right? Your EHR partners, it was critical. So yes, we had that happen quite frequently because they don't want to be it and then be on the hook to resolve it. But the beauty of Goliath, right? It allowed us to have that common set of facts, right? To say, okay, we know exactly where the root cause is, and so there's no argument here, right? You can have your opinion, but you're not entitled to your own facts.
Yeah, you don't have to come in. You can come in and have a common set of facts and focus on the solutions. Just cut right past that finger pointing, which is, to me, a wonderful experience. Having said that, I always like to focus on the so what, right? We spend a lot of time discussing the issue, talking about the solution. So now what, right? What do we do with this? And one of the things I would recommend, highly recommend, is engage with us. And one, you could reach out to me or Curie or Mike. I think we'll pop your email up here in a second too, Mike. I think you'll probably get heavily recruited now or something. But unfortunately, everybody wants Mike to work for them. But engage with us. And one of the ways to do that is through our speed and reliability program. That's usually 60, sometimes a 90-day engagement where we come in with a technology-enabled service, help get visibility and troubleshoot and fix these issues. Oftentimes, we're seeing dramatic improvements like you've seen, Mike, in the 45-day or less time frame. But that's one way to engage. But in addition to that, some health systems have IT teams and they say, hey, give us that technology and let's get a subscription and we'll roll with it, whichever works best for you. But another way to engage is just call us and have a conversation. We're happy to kind of point you in the right direction, talk about if you have specific issues, how we might work on that with you. But feel free, that's what I would recommend. Don't take this time and say, yeah, fantastic. I would engage, reach out to us. And so my email is right up there, ryan.oliver@goliathtechnologies.com. And we'll do a discovery process with you, have a conversation. We're happy to do that. Anything else you would add to that, Mike or Curie?
Yeah, we've got a lot of questions that have come in. You guys have done a good job at I think sparking some curiosity. So if you don't mind, we'll go ahead and jump right into some Q&A time. While we're doing that, we'll make sure that we get links to the email addresses dropped into the chat as well, so you don't have to necessarily take a picture of the screen. But we'll get links to the email addresses in the chat, and we'll also drop a link in there as well that will take you right to more information about the EHR Speed and Reliability Improvement Program. Again, if you've got questions, and we're going to jump into it now, but if you've got some questions, it's not too late. Go ahead and type your questions into that question and answer toolbar, and we'll go ahead and get to as many as we can with the time remaining. All right, Ryan, first question, I'll kick it over to you. How long does a typical engagement take? And actually, you can speak to it from a Goliath perspective. Mike can speak to it from a client perspective. So if you guys want to sort of tackle that.
Yeah, I think that question probably came in before I showed this slide. And but I think an average is if someone's just using a speed and reliability, our speed and reliability improvement program, 30, 60, or 90 days. I would say 60 would be more of an average. And I think I described sort of how quickly we can deploy. A lot of that time is just taking the data and then fixing the real issues with it. Mike, what's your experience?
Yeah, I think our experience was, I think we talked about it a little bit, we had an awareness of Goliath before we broke that glass. So I would say we were flirting. We had some of these preliminary discussions. We were familiar with technology. And so once we decided to go, it was quick on both sides, right? So, once we got through the administration process, that was probably the longest, right? Just getting into contract once we decided to go.
Okay. What does the initial consultation look like, Ryan?
Yeah, initially we'll just jump on with your team and identify what issues that you are having, which virtualization tools you're using, what your infrastructure stack looks like, and then just share with you real quickly, like, hey, what are the next steps? How do we deploy and get started? Or just share with you examples of similar type customers that that maybe are using a similar infrastructure stack or using the same EHR and what they've done to do that. I think it's also important to note when you engage with us, if you're on Oracle Health, for example, we are the only technology deployed in their hosted environment. So you will immediately, when you deploy, we will work with your Oracle Health customer service representative to deploy, and it'll pull data in that you really can't see anywhere else. And it sounds a little counterintuitive because we're not using that data to see the same thing Lights On is looking at. It's not to look within the application, but it's the telemetry to look at the overall experience and then immediately give full view of the end user scorecard, like right at their device. What is their experience? What is it happening? The other neat thing about it is it's 100% of the users that we can see. You know, if you think about, I love the Arch Collaborative and the KLAS data and the perceptions, but you launch a perception survey and you might, KLAS gets a really high response rate, sometimes 20%, but you're not seeing everything and everybody, and it's perception. So this is the real scorecard of the speed and reliability. It's looking at something very specific, what's happening on their devices, and very usable data. And then Epic, we're fully integrated with Epic. The Pulse data comes in there also, but we see the client side infrastructure issues there. That's really what we're focusing on. I would say about 70–75% of the time, the issue is not the EMR vendor or their hosted. Majority of the time, it's within the client's infrastructure somewhere. I got a little off track on that specific question.
Hey, Ryan, let me add to that real quick. You know, I would say that, you know, before we got on contract with you, am I talking over Ryan, Kerry?
But I did think it was important that's kind of where we're going to be going.
I think he had some latency.
We have that initial conversation, what's going on here, right?
Hey, Ryan, I was going to add to that. I think one of the things that helped us was—
That's my home lanes.
All right, go ahead, Mike. I muted Ryan for a second.
Okay. What I was going to say is I think one of the things that helped us, Ryan and Kerry, was having some of those preliminary conversations before we had to break the glass, right? So we had a lot of the discovery sessions, and so there was a lot of information sharing before we actually moved the contract, which certainly helped us accelerate moving into implementation.
Yeah, I think Ryan's having some technical difficulties again. He looks frozen there. We still got, that's all good. We've got several more questions we can tackle, I think, between yourself and myself, Mike. One of the questions came in, Ryan actually just mentioned KLAS. Do KLAS members get a discount? The answer to that is yes. So if you're, we are members of KLAS. If you are a KLAS member as well, and you've measured and you want to actually tackle some of the EHR speed and reliability issues that have been exposed, we're happy to work with you there and offer discounts to KLAS members. So no issues there. All right, so you guys actually both answered a couple of these other questions in there. One was specific to Oracle. Do we work with them? Of course, yes. Same question applies to Epic. This person must be staying up late on a Friday night because they were wondering if we work with clients in the UK. So yes, we do. We work with a lot of clients globally, and we've got them, both in healthcare and in enterprise. So, all right. Last question. Just making sure I didn't miss anything here. We jumped around a little bit. Oh, actually, there was two more questions here. Mike, you can actually speak to this one. The question is, how do you present results? From the program. So working with Goliath, how did we present results to you guys? One of the ways, obviously, we just showed a few minutes ago with the scorecard. But how else were results presented to you all, Mike?
Yeah, I think that's a great question. I think, the scorecard is a big win, right? Making sure people understand what that looks like. The executive leadership, both in infrastructure and within the leadership of the healthcare system, I think was important, right? The folks that are responsible and accountable to the clinicians, making sure they understand what we were doing. But also think each one of these instances, what we tried to do was quantify the benefit, right? So that we had an issue that we were able to resolve with Goliath, kind of doing that before and after. This is what it would have taken, and this is what it did take, and making sure that we told our story internally, because you got to continue to sell it, right? So, looking at each one of those instances, making some logical assumptions about, what it would have taken in terms of manpower and hours and duration, and comparing and contrasting. And, this is what the quantifiable cost avoidance that we were able to achieve. Those are some of the important, I would say, capturing each one of these business cases, use cases was key, right? To make sure that you have an understanding across the enterprise of the value that this capability is bringing to bear.
Those are some great points. And you're right, it's not a one and done engagement. There's a continuous engagement. You sort of have to continue to sell the idea that, you fix one problem, and that's sort of the break glass issue, but you have to make sure that you don't have any more of those issues that become break glass issues. So it's an ongoing engagement. All right, last question before we go ahead and wrap up. It's always the big question everybody's wondering, what is the cost? And that really just depends on the size of the user base that you're working with and what it is that you want to accomplish. So it's a matter of just a quick phone call with someone on our team, and we can get you to an answer. But typically, the speed and reliability improvement program cost is usually somewhere between 25 and 50K. So, but again, it really just depends on what you want to accomplish, or need to accomplish, I should say, and what the size of your user base is. All right, so we are just about at time. We're going to go ahead and dial it back in, come into a wrap up. Any closing statements from Mike and Ryan? We'll give them an opportunity to, but just
yes, I have.
Again,
I have one closing statement disclaimer. Goliath is not deployed at my house. I must be a connection issue. I'm not sure. I'll have to change that.
It would be able to fault isolate what your true problem was, Ryan, if it was.
That's right.
So
That's right.
I wanted to say thank you.
That takes more than technology.
Right. I wanted to thank you, Ryan and Carrie, for this opportunity. Appreciate everyone's attendance and interest.
Yeah, Mike, again, we appreciate you jumping on and sharing some of your firsthand experience. And Ryan as well. Ryan is relatively new to Goliath. As you said, he came from KLAS, so he's been in the thick of it for a lot of years, sort of working with clients across the spectrum in the healthcare space to understand where some of their issues are and how they can be addressed. So thank you both for your time today. Just as a quick wrap up, if you're interested in learning more, we've got a QR code here. Of course, we dropped some links in the chat, so you're welcome to reach out, learn more. As Ryan stated, you can reach out to any of us on the call today if you've just got some additional questions. You're not committing to jumping into a sales conversation. We want to just answer your questions if you've got questions. And then we have our next Health IT focused webinar coming up on May 22nd. So we'll be sending some information out about that as well. So again, thank you all for joining the session. Again, Mike and Ryan, thank you guys as well. And until next time, we are going to go ahead and wrap up for today. Thank you very much, everyone.
Thanks.
Thanks, everybody. Bye now.